and always try to talk to them. These are the important things you have to keep in mind when you give an intrascalene block. She had a hypoxia under an intrascalene block. Now you see how this patient, he was a known case of chronic obstructive airway disease. He was posted for a shoulder fractured shaft femur. I had given him an intrascalene block. Now this fellow is, I had given just 10 cc, and I'm just waiting to see whether I have a good action. And this was done under an ultrasound, and I gave just 10 cc, lateralizing it so I don't have a phrenic nerve. And he has started, the surgeon is almost starting with the procedure. He has got a painless limb. And now you see the type of respiration. Can you see that? Yeah, that means he had a phrenic nerve palsy even with just 8 to 10 ml of local anesthetic, even with an ultrasound-guided intrascalene block, even with a low volume. And this we have often seen all the time when I use an intrascalene block with spinal anesthesia for a laparoscopic cholecystectomy. So that what happens is that on one side, the patient has got a phrenic nerve palsy, and the patient can, the surgeon can operate comfortably, and at the same time, the patient does not have a shoulder pain. And with this, we have seen with the laparoscope pointing towards the diaphragm, on the other side, it contracts very vigorously. It does mean that in these kinds of patients, you have to be very careful. See how it has delaminated the anteroscalene muscle. This runs all along the phrenic nerve. So that is a phrenic nerve block occurring during an intrascalene block. And if you put in a catheter, and if you put on a continuous infusion, you are likely to get a continuous phrenic nerve palsy in the postoperative period, even with 0.2% ropivacaine. So you need to be very, very careful in patients with chronic obstructive airway disease. Some of the other complications, lower lobe collapse, hypoxia, auditory disturbances, persistence hiccups have been mentioned. Coming to neurological complications of intrascalene, there are some cadaveric studies which have found that there is almost extension of dura mater for up to 8 centimeters. And madam, I think it was mainly because of this that the patient had a respiratory complications, neurological complications, or the respiratory complications in the postoperative, during the block period. You are getting your needle here, and you're directly into the subdural or the epidural space. You inject the local anesthetic, it acts as an epidural. And that's why it acts as a cervical epidural, where the patient is unable to move the upper limb, is totally conscious, and moving her lower limb. And that's why this can be a delayed when it's subdural. It can be immediate if it's an epidural. It can be a total spinal if you are inside the dura. So these are the problems when you have this. These are the neurological complications. Now another thing is that when you dip your finger in the intrascalene groove, it means that you're bringing the tip of the needle very close to the intervertebral foramen. So keep it in mind that the distance between the skin and the intrascalene trunks, which has been mentioned in the literature, is a distance which they have measured on the cadavers, or they have measured it on the CT scan. And these are not the distances when you dip your fingers in the intrascalene space and then put in your needle. That is going to get the needle tip very close to the central column. So the skin intervertebral foramen is 3.7 centimeters, and a 2.5 centimeter needle has been recommended by these authors. So there are some of the complications which have been elicited in the literature. So the length of the needle should be less than 1.5. Be alert for all painful paresthesias. Avoid unexpected movements during the blocks. Should not be done in unconscious patients, certainly not under general anesthesia, and direction of the needle has to be perpendicular to the scalene muscles. Do you know where the catheter tip lies with this? I do not know, but when you take a CT scan, you can see the catheter is coming very close here, and then when that is the scalene muscles, and that is the nerve root, and these are the trunks, and that is the vertebral artery. So the distance that the catheter has traveled is 2.5 centimeters. If I have inserted more, it would have been gone into one of these spaces. So the catheter insertion should not be more than 3 centimeters in any case. In infraclavicular, 5 centimeters okay. In the paravertebral, not more than 3 centimeters. In the lumbar plexus, not more than 3 centimeters. In the sciatic, not more than 5 centimeters. This we have seen. So tunneling of the catheter is one where you can, I always do for all these patients, and it's necessary because the catheter should not eventually come out from the space. So that we do quite routinely. Now, why visualization of sonor anatomy makes sense? See, this is the sternocleidomastoid, gives off the local anesthetic. Ultrasound guided catheters, it makes sense in placing because when I injected contrast under, you can see it delineates right from the cervical root, trunks, divisions, and cord. So it makes great sense in using ultrasound for when you place your catheters. Another thing is that recognizing vascular anomalies. Don't think that interscalene is very easy block. Please don't think that, because if you see this is the cervical root, this is another cervical root, and there is something going in between this. I was a bit surprised of what is going in between this. I thought whether it's a vascular structure, and when I applied Doppler, I could really see that in between the upper trunk and the middle trunk, I could find this dorsoscapular artery. This was an aneurysmal dilatation of dorsal scapular artery. If I would have injected local anesthetic in this particular area, the patient would have definitely had some problems. So that was easily placed, local anesthetic over there. Another thing is that you could find sometimes, you could see this is the scalene muscle, that is another scalene muscle, and if the needle would have arrived from here, definitely it would have caused a huge hematoma. So that's why you get in the needle from the other side and get your block done, because routinely the needle comes from here, and this would have perforated this artery. This is another anomaly that we had come across. I always keep the patients awake, no sedation. Coming to the cervical paravertebral block, I don't know how many of you do this technique. It's done basically for pain relief, but if it's directed too medially, it can cause neurological problems and vascular problems. So you better be careful when you use this paravertebral block, that the needle is brought from the behind. And this is one very important thing. I did one cervical paravertebral, and to my surprise, I found a pop. This was with a 23 gauge needle. I was doing a paravertebral neurolysis for chronic pain. And to my surprise, the needle went directly into the cervical spinal cord, and the patient did not complain of paresthesia. Even if you stimulate several times the spinal cord, the patient is not going to complain of pain. But when I removed the stellate, I knew that I was having some problem, and there was a CSF which was coming out. Unfortunately, I could not have that photograph right now. But then you have to be very careful when placing the needle. See, the patient's axis has been tilted. And that's what makes the difference when you give the block in these kind of patients. And the anatomical landmark is totally incorrect when you don't place the patient in the correct position. So eventually, you have to reposition this needle. And there are several problems which have been mentioned, unconsciousness and neurological injuries with this block. And that's why it's not much used in our part. So this is infraclavicular. You just pay attention to this. I have this good response. You can see that response, it's quite good, extension response. I give 0.5% of bupivacaine 10 ml, and then to my surprise, you can see the patient is awake at this point. The patient is awake, totally awake. And the next what I see is the patient convulsing on the table, because then I can see that in the aspiration there is total amount of blood. You can see the patient had some convulsions on the table. I immediately sedated him with 10 milligrams diazepam. I had pentosol ready. I then oxygenated him. And to my surprise, with the contrast which I usually take, I found that there was some blob inside the intravascular lumen. This could be part of the drug going inside the intravascular lumen. The surgery was eventually carried out, and we had this procedure done. The patient was sedated, of course. He woke up after some time. He said, "What's happening?" I said, "You're fine." And then I found that he had no neurological injury. So all this has to be documented in front of the surgeon, that there are no problems whatsoever. I took him to a CT scan center. I then catheterized him. I found this contrast in this area which was still there. There is no contrast elsewhere in the body. It means that it has not gone intravascular. It is still in that compartment. Yeah, coming to this, I think we'll end up with thoracic paravertebral catheter, because this has not been discussed. This is the catheter in the paravertebral space. This is done again by Dr. Desai. She is here, and this is very nicely placed. You can see that it's very nicely placed. Hypotension and pneumothorax are quite possible in this case. Again, the same patient who has the paravertebral catheter, but this has gone a bit more inside the, see how the catheter goes. So that's why you have to see that the catheter does not go more than 3 centimeters inside the paravertebral space. And when you inject the drug can go either periaortic, it can go in the contralateral side, it can go on the same side, and it can also go in the epidural space. So these are the sites where your local anesthetic can eventually go. If you have a mass here, like a cancer pain patient, you have a mass here, and if you give a parietal block, the drug is going to go into the posterior space. Posterior space, neurolysis, I don't mind if it's for a few segments, but anterior space, definitely I would hesitate to inject alcohol. Again, you can see the contrast here in the anterior space. I would not inject any amount of alcohol over there. See the amount of contrast again in the anterior space. So these are some of the complications which you can demonstrate on CT scan, and that's why it's very important to have some of these modalities at your hand. See, almost a pleural puncture. I had hit the costotransverse junction. I went beyond that, and then I said, I'll wait. I won't go beyond this. You just take a scan. I told a technician who's also quite efficient. He said he did that, and I would have gone a bit beyond this. I would have landed in the pleura, causing a pneumothorax. So I had to again reposition the needle. Very important, again, a complication which could be avoided because of this CT scan. So even if you look at the space, the parietal space, all the time the catheter may not lie like this. And even if you needle the pleura once, you can have a pneumothorax like this. And even if you insert the catheter, it may not lie all the time in the same place. Just a few words about complications of epidural. You have seen Dr. Selamban mentioning about the epidural. Now, in geriatric group, because of the closed intervertebral foramen, a small amount of drug in the epidural space can go at a very high levels. Now, this is just 8 ml of local anesthetic given into the epidural space, causing a cervicothoracic, a mid-thoracic, a lower thoracic, and this I find that there is small amount of subdural placement of the drug, and then the lower thoracic area, and you can see the catheter going in. So a small amount of local anesthetic, just 8 ml, can cause a very high spread, and you have to be very cautious. Subdural block in one of this last case report, and then we disperse. In one of the patients, what had happened was she was quite okay. Hemiarthroplasty was going on the left side. She was in the lateral position. I had given an epidural. All was going well. The surgeon said, I want some relaxation because she was a very high risk case. I want some relaxation. I said, okay, we always have that curtain between the surgeon and the anesthetist. I said, fine. So I injected some amount of local anesthetic, and I found that the patient was a bit, she was a bit having some problems with respiration. So I said, I called the attendant. I said that we keep everything ready. We have everything ready with us. So I knew that something was going on, and then suddenly she stopped taking respiration. There was bradycardia. There was some hypotension. We gave atropine vasopressors, intubated, ventilated. The surgeon asked me what's going on. I said everything is fine. You don't worry. Now, what had happened was this local anesthetic might have gone somewhere in the subdural space or in the spinal space. We don't know that. There's no time to think during that. We just want to get out of it. So once that was done, I took her next. To the radiology department, which is just downstairs, and I found that when I injected local anesthetic, part was in the intrathecal space. You can see that. Actually, the catheter, it lies here. See, this is the T12. The catheter, it lies somewhere here, and it was at a very high level. You can see the spread. It's gone too high. See, so it could be either in the subdural space or in the intrathecal space. So always keep it in mind that whenever you are giving a top-up, just remain with the patient. Don't leave the patient. In fact, whenever you are having a regional technique, don't leave the patient. You have to be with the patient all the time. You can have your coffee or biscuits later on and in the later part of the day, but during that procedure, you should be always with the patient. Now, this is very important because you can see this figure, how there is a very small relation between, we have dissected this. You can see this is the subdural space. This is the dura, which is so slimy. And it is mentioned in the literature that when you inject the local anesthetic, the initial part with the syringe, when you identify the epidural space, you inject it very fast, then you open up the subdural space, and the drug is likely to spread in the subdural space. And then when you pass in the catheter is also in the subdural space. So when you inject your local anesthetic, be very careful in all the blocks. You have to give in aliquots, aspirate, give in aliquots, aspirate, give in aliquots. So that is how you do your blocks. So please don't be borrowed about all these things. You will come across some or the other time, and don't forget to mention it because we have just published our newsletter, and which is, I think you have received it. And it's good that if you can send some of your very, very interesting case reports. It could be a complication, we don't mind, because this is how we get aware of the problems. So I thank you all for being here, and